So, good afternoon, everyone. Welcome to this session. We will speak about mucus management in muco-obstructive disease, why and how. And for that, we will have, first of all, an update about mucus clearance in bronchiectasis. The speaker is Professor Anthony De Souza. Professor De Souza is pulmonologist at the Newcastle University Hospital, and he is leading the bronchiectasis clinic. So, Professor De Souza.
Great, thank you. How many of you here are physiotherapists? Brilliant, I'm playing at least to a friendly audience. So I am so passionate about physiotherapy as part of a treatment bronchiectasis. I have too many slides, so you're not really going to get to see my slides because I've been strict on time. I've got into bed with pretty much everybody who can make bronchiectasis care better, and if I haven't got into bed with you yet, I'm about to. I'm not going to tell you about bronchiectasis in the interest of time, but just note one of the key elements is sputum. You know this diagram incredibly well. It's a different variation of the vicious cycle or vicious vortex, but right up here at the top, mucus hypersecretion. And I think it's a really key target that underpins all of the other treatments that we do. As you know, other guidelines are available, but British Thoracic Society guidelines, airway clearance techniques early, and pulmonary rehabilitation as well. The bronchiectasis passport in the UK or the European Lung Foundation, I know the importance. So the guidelines are saying airway clearance is a key. So I don't need to convince you because your guidelines tell you, the clever people that wrote them, or that was me to a degree. So why is physiotherapy so early? And this is the point I'm a little bit less on strong ground, and I can show you why. So you all remember this really famous paper led by colleagues in Edinburgh. Very small sample size, an important point to make. But patients had more sputum when they were doing physiotherapy. They felt loads better with the quality of life. Interestingly, the bacterial count wasn't clearly different. James and Arietta did a beautiful analysis of the guidelines and basically said most of our guidelines in bronchiectasis are weak, but also actually our physiotherapy strength is relatively modest, okay? So all physiotherapy, although I absolutely believe it to the core of me that it is vital in bronchiectasis, we as a community need to be doing better. We need to be doing more research studies to make these evidence grades better. So there are more physiotherapy studies coming, so I would strongly encourage you, whatever stripe you are in terms of the multidisciplinary team meeting group, physician, physio or other, to be pushing to do these studies. So here's a study coming from Australia. I'm involved as one of the co-applicants in this study. We'll be reporting this certainly by next ERS, if not earlier. But I also wanted to draw your attention about this really interesting device you're going to hear about more about later, which there's a trial and the company are looking for more sites now. So if you're interested, please do get in touch with the team here. We've got a better framework for how we evaluate these studies. And I just want you to think, because you probably were at A1 or not at A1 earlier, because it was so full of people. It was brilliant. I couldn't even get into the bronchiectasis session. That just to think of how physio fits in context of other targets. So we've got some interesting new drugs that have had to read out their anti-inflammatories. So we know that nebulized antibiotics work in bronchiectasis, or they don't. I was involved with the Respire trial. One was positive, one was negative. And a consistent theme comes out is we need quite big trials in bronchiectasis. When you do them as a meta-analysis, it reduces exacerbations. If you do a small trial, potentially even as small as 400, and that's quite big for some settings, you can get a negative study. So inhaled antibiotics work, but can you imagine trying to give an inhaled antibiotic to kill bacteria if you've got millimeters thick of mucus secretion there? It makes no sense. So these treatments supplement physiotherapy. You've also probably heard about neutrophils. and brensocatib. These slides can be shared later, so I'm going to go through it quick. But we know the brensocatib is, we haven't seen the primary paper, but there's a phase 3 stock market release showing it significantly reduced exacerbations. Just remember, though, that this was in the setting of what was felt to be each centre optimised basic care, that they were already doing physiotherapy. Now, I just want you to remember that there's a number of papers, some of them have my name on them, that if you take bronchiectasis sputum and you take an extract of it and put it in human tissue cultures, it's hugely inflammatory. So sputum is full of inflammatory pro-mediators. So leaving that festering in the lung is really unpleasant. So to make you think of more unpleasant things, this is what I tell my patients. Mucus is made of protein and carbohydrate. You probably had it for your lunch. If you leave it lying around for days, it festers. And the treatment for that horrible mouldy sandwich is not bleach spray, it's to physically remove it. You have to leave really strong messages with your patients. Here, to answer the anti-inflammatory side of stuff, at the top right-hand side is a mucus plug with micro abscesses in it. You cannot clear an abscess with an antibiotic, and you cannot clear that abscess if the airway is full of mucus because there's nowhere for it to discharge. So my summary is that I absolutely believe to my core that physiotherapy is really important. The big unknowns to me are which device, in which patients, and when do you decide to change? What sort of treatments are more suitable for outpatient care, and what devices might be more suitable for inpatient care, and where does that blur? We need to be really ambitious and do more trials, and you guys need to be here in this room, up on this podium, saying, Tony challenged us, and we did the trials, and here are the answers. So there's lots of people to thank that have been involved in bronchiectasis care, but I really want you guys to be engaged in the future trials that we have. And with that, I'm happy to take questions or move on to the next presenter as needs be. Thank you.
Thank you very much, Professor De Souza. We will keep the question for the end of the session. The second speaker, the second and third speaker will present clinical cases in hospital and at home. So I invite, it's my pleasure to invite Laurence Vignaux. Laurence Vignaux is a PhD physiotherapist and chef of the medicine physiotherapy department in the University Hospital in Lausanne, in Switzerland. And she will speak us about a case of an hospitalized patient treated with Simeox. Thank you, Laurence.
Okay. Ladies and gentlemen, colleagues, Mr. RABEC, good afternoon. It's my pleasure to speak with you about our clinical case in an hospitalized patient. It was a severe obstructive patient with bronchiectasis complicated by multiple exacerbations and hemoptysis. Briefly, this is a 30-year-old male working and living in Switzerland as an engineer. He is married without children. He neither smokes nor drink alcohol and has a sedentary lifestyle without any regular exercise because of the shortness of his breath. The primary diagnosis is a predominant bilateral lower lobe bronchiectasis. The diagnosis was made during the childhood and with an initial follow-up in Paris. A very extensive workup failed to reveal any etiology, in particular no cystic fibrosis. From 2021 to our clinical report, the patient presents with 6 exacerbations due to an infection. He also presents a familial Mediterranean fever treated by anakinra, and to note, despite hypogammaglobulinemia, the patient presents good vaccine responses. The pulmonary function tests show a severe obstructive syndrome with a FEV1 at 40% of predicted and no reversibility post-bronchodilation. There is no restrictive syndrome, and as you see, a very small evolution since 2015. In June 2023, the patient experienced hemoptysis that required a prophylactic embolization, and he was hospitalized. During this hospitalization, the diagnosis was made of pulmonary tuberculosis, and the sputum analysis revealed colonization by Pseudomonas and Mycobacteria. Daily, this patient expectorates significant amounts of sputum. The exact quantity has never been measured, but the patient reports something like 10 expectorations a day with several coughing bouts. He benefits from respiratory physiotherapy 3 times a week, but refuses absolutely any rehabilitation due to a lack of time. He has inhaled treatment with mucolytic agent and bronchodilation. He experienced outside of the hospital breathlessness with a MMRC from 2 to 3, and tried sport but without any success because of the breathlessness. He has a mild degree of malnutrition despite normal body mass index. In September 2023, the date of the clinical report, the patient was hospitalized in the medicine department at the Universitaire Hospital in Lausanne for 3 weeks due to an infectious exacerbation. The antibiotic therapy and an intensive respiratory physiotherapy were initiated. Then he presented again bronchial bleeding of an infectious origin, which warranted bilateral embolization. Because of the inability to clear secretions and worsening dyspnea, he was transferred to the intermediate care, where the following techniques were sequentially applied. First, we try manual chest physiotherapy with expiratory flow acceleration techniques. Then we added a vibrating PIP device. In the light of absence of success, we tried in inspiratory assistance with NIV, and then after we tried to add intrapulmonary percussive ventilation during the respiratory sessions. To note, because of the bleeding, we couldn't give him some inhaled treatment with mucolytic agent. So despite all of these techniques, the secretion clearance remained ineffective, and the patient condition did not improve, so it was therefore decided to try Simeox. The intermittent intrapulmonary deflation technique for airway clearance is a bronchial drainage technique. Briefly, during the exhalation, the device generates negative pressure intermittently at 12 Hz, and this technology is based on the rheological property of bronchial mucus. Additionally, it could decrease the risk of expiratory flow limitation. During the session, the patient inhales through the nose and put the mouthpiece in the mouth, activate the device with a remote control, and then passively exhale up to the maximum tolerated. And caution has to be paid to not obstructing the mouthpiece with a tongue suction or the glottis fermeture. The efficiency can be seen with a green light up on the device. There are no parameters to be set on the Simeox except the power, and the power that can be set from 25% to 100%, and it allows the variation of the amplitude of the negative pressure during exhalation. During one session, so the goal is to start at the start of the exhalation to start with 100%, and at the end of the exhalation to be at 25%. First, the adjustment is made by the physiotherapist, and then secondly, it's made by the patient himself. We started with 25% with a fixed rate. Okay. So the session is 3 sets of 10 respiratory cycles with a 45-second rest in between, and the total time was around 20 minutes. After 2 days, the patient was totally independent. At short term, during the 2 days, two first days, the volume of secretions per session and per day drastically increased from three secretions a day to 10 on the first day, and then more than 20 on the second day compared to previous techniques. So the duration of respiratory therapy sessions decreased from 45 minutes initially with the previous technique to 20 minutes with the Simeox, with a marked improvement in fatigue after the clearance session and during the day. During the hospitalization, the patient was advised to do as many sessions as possible, and 2 times a day a physiotherapist went to see him and to guide and to control that it was made. During the session, the MMRC progressively improved and went from 4 to 3. The chest CT scan before and after show the highly efficiency of the clearance because of the device. Today, the patient performs 2 sessions a day, totally independently. We lent him a device at home because the insurance in Switzerland does not cover this kind of device, and it took us 10 months of fight by our pulmonologists to obtain that the insurance accept to cover this device. Now, today, this patient has no experience any new hospitalization for infectious exacerbation, no more episodes of hemoptysis, and the expectoration level came back to the usual level. The pulmonary function is stable, and the patient could return at work. Globally, he is totally independent and does not want absolutely to be part of the machine. He said that it's easy to expectorate, that 1 session is 15 minutes, and during the day he has less coughing bouts. So, as you just said, it's difficult to choose any technique, the right technique for the right disease. But in the non-cystic fibrosis bronchiectasis, the ERS just recently recommended that the bronchial drainage daily, but no recommendation is done on any technique. Perhaps we could prefer this one, first because this is a physiologically based mechanism of action based on rheological properties of mucus, and perhaps limiting the risk of flow limitation. This is somewhat an effective technique. It seems that it could be more effective and faster, and so less fatiguing for the patient, and moreover, it's easy to use and allow the patient to be independent. This is not an anecdotic point, because you can have the best technique of the world. If the patient does not use it, it doesn't mean anything. So perhaps this machine could decrease the burden of the pathology. So, in our opinion, this machine in hospitalized patients could be useful for two indications. First, to clear secretion in an obstructive patient with hypersecretion and with a lot of fatigue and with a failure of conventional techniques. And secondly, perhaps it could be the place to determine the need for this device at home and train patients before returning home. So, So in conclusion, this technique of bronchial drainage was efficient in our patient obstructive disease, severe obstructive disease with bronchiectasis and hemoptysis during the hospitalization and after, perhaps at least contributing to the fact he had no more exacerbation today. More in-hospital studies are needed to explore patient outcomes. And in our opinion, it would be useful to investigate two more aspects. First, explore the timing to introduce this technology. And secondly, perhaps including this device in the list of insurance-covered equipment. Thanks a lot.
Thank you, Laurence, for this very nice presentation. We will move to the next speaker, that is the Dr. Mensch, that works in the pulmonology department at the Universitaire Hospital in Munich in Germany. And he will speak about a clinical case at home, to be complementary with the clinical case presented before. Thank you.
So, thank you for the kind introduction and also for the invitation to present our experience with the Simeox in clinical case, or Simeox at home. So, for of interest, when we first got to know about the Simeox and were thinking about using it in our patients, we had some questions, because usually if I'm treating a patient, I have an idea of what I will achieve or what I try to achieve with this treatment for the patient. But with the Simeox, I was missing every clinical experience on how it would work or what this will, how my patients will benefit from this treatment. So the questions were, which patients will really benefit from the Simeox treatment? I had a rough idea from literature. How does Simeox therapy fit in with already applied chest physiotherapy, and how satisfied are the patient with the therapy, of course, and what effects are the ones they notice? So I want to start with a clinical case first. We have a male patient, 80 years old, suffering from COPD. He's treated since 2020 in our COPD outpatient clinic, and if you look at the numbers, he's a really sick patient. It's Gold C, he's a heavy ex-smoker with 50 pack years. His lung function is severely impaired, and he has had 3 exacerbations in the last year. In lung function, we see a severe obstruction with severe hyperinflation. The FEV1 is about 34%. He has a severe resting hypoxemia as well as impaired diffusion capacity. He's underweight, and on the CT scan, he has bronchiectasis. If you ask him about his respiratory symptoms, he says he has daily cough. He has purulent sputum. You also find some pathogenic bacteria in the sputum and find it repeatedly. And he has a hoarseness, which is a problem for him because he really likes to communicate with his family and friends. The functional status is also severely impaired. He has severe breathlessness with an MMRC of 4. The CAT score is quite high with 30 points. He could only walk a few meters and is suffering from recurrent panic attacks. So if you look on the right lobe, this is really he really looked like this pink puffer here and had some expectoration. So how is he treated? He has quite intensively treated with triple therapy. He has long-term oxygen. He does also inhalation with ISO and hypertonic saline. A few years ago, he had endoscopic lung volume reduction, which initially brought some effects, but then this has already been gone. He also used PEP devices, gets regularly chest physiotherapy, so supervised once a week. And he, because of the severe breathlessness, we also had a trial of opiates, which he didn't tolerate and didn't want to start again. So our question was, how could we improve this patient's respiratory situation? And when we thought about this patient, we thought, okay, what are his problems? So the one is this cough in the sputum. He had problems to mobilize because it was really, he just couldn't get it out properly beside this really intense treatment already. The other thing was he had chronic infection with bacteria, which also, and COPD described with more symptoms and more exacerbations. Hyperinflation, of course, was a problem. And the last point was that with COPD, progression of his COPD, he's obviously an end-stage COPD patient, he had an increasing loss of muscle strength. So the mucociliary clearance as well as the hyperinflation seemed to be a crucial treatment for us, and we gave him a trial with the Simeox. 3 months later, we saw him again, and we asked him what were the impacts you having from the treatment. He said he looked a bit better. He was still very ill, but he looked a bit better, and he said, I could mobilize my sputum better. I have less sputum during the day. My dyspnea is slightly increased. He has the feeling of getting more air, which is quite relative, into his chest, and he had less hoarseness, which was really important for him because now the communication was much easier, and this was something that was disturbing him. And this was also stated by his wife, he had really, he felt a bit better. The quality of life was better as well as the activity on a really basal level. We tried to look at objective changes, and what we saw is a slight decrease in residual volume, so the hyperinflation got back a little bit. He had no further exacerbations in the really short follow-up of 5 months, and he also continued to lose FEV1 as he did already before. So is this the typical patient we are treating in our patient? I would say no. It's he's just one example of patients we are treating. But he really, from quality of life point, it worked well for him, and he's quite old. So I had some doubts about how it is working for him, working with this Simeox device. To get a better overview, we have now 20 patients we treated with the Simeox. We offer it to every patient who has problems mobilizing his sputum, so high symptoms or a lot of exacerbations, despite already good basal therapy, including nebulizers, isohypertonic cell line, chest physiotherapy, and PEP devices. And we offer this to the patients. So if you would like to try it, you can try it. So we have offered this between March 23 and May 24. We offered it to 20 patients, and these tested it for 2 weeks and were advised by PhysioAssist how to do it just remotely. And this works quite well. 7 of these patients decided, I want to use it at home. 3 patients said, I don't see the effect, or had other reasons to not use it. One of these 17 patients, we got it reimbursed for 5 ones, which is quite good. It's quite a lot of work for all of us, but we of course wanted to know how these patients are doing. So for this talk, I sent a questionnaire to our patients and asked them what are the effects. And this is really, it's biased because it's only patients that were willing to do this therapy. So of 15 patients, 12 responded, which was really nice. The mean age was, you see, it's a bit younger than the case I presented. It's 53 years old, but ranging from 19 to 80 years as well. There's the FEV1, it's 50% in mean, but we have really severely impaired FEV1 as well as almost normal FEV1. But all of these patients had hyperinflation in quite a relevant grade, and 9 of 12 patients had bronchiectasis. So what were the primary diagnoses? It's asthma, COPD, of course, and the rest of these patients is bronchiectasis, so we excluded the cystic fibrosis patients here. When you look at the therapeutic burden these patients have, you see that the number of regular respiratory therapies, either devices, techniques, or medications, is quite high. So most of the patients have 4 or more techniques they use. And if you look close at this, it's almost all of them use nebulizers, chest physiotherapy, inhalers, daily drainage techniques, try to train. So it's quite an intense treatment. Of course, there was a question, are you satisfied with Simeox therapy? Most of them were very satisfied or satisfied. One said, well, I don't know, I'm neutral, whatever that means. But I think the more important picture or graph is on the right side, because here you see how often do the patients use it. And it's only 3 patients that use it less than at least 1 time daily, and 4 of the 12 patients use it twice daily. So this is patient reported, but this shows, actually, in my opinion, if you have a high adherence to the therapy, it somehow should work. And at last, we asked the patients, what are for you the positive effects you feel from this therapy? And they said, exactly as my colleague here described before, sputum is easier to expectorate. It's an increased volume in sputum I can expectorate. I have the feeling that the deeper airways are better to clean. The sputum is a bit more fluid, and which I think is a really important point is too the shorter time for sputum mobilization, because if you apply it every day, this is like time of your life, and if it accumulates over quite a large number. So less dyspnea. Some of these patients said, "I'm having less exacerbations." I can tell this because it's only like it's their personal what they think it helps. But I think this is quite positive. We also asked, "Did you notice any negative effects?" So they said, "No, I didn't notice any negative effect," which is nice. So to conclude, I have only 10 minutes, I guess. The therapy with the Simeox is easy to carry out and used regularly by most patients, which is important because none of the patient was trained during hospital. They just were remotely trained how to use it. Also, the group of patients with secretion problems, and hyperinflation, most patients were satisfied, very satisfied with the treatment. Of course, this is a biased group, and the positive effects of the patients include easier, faster, and increased mobilization of sputum, and no negative effects were reported. And that's my talk, actually. I'm done. So if you have any questions, I'm happy to take it.
Thank you very much for this very comprehensive and nice presentation. Please take place. So we have some minutes for questions. There is any question in the room? Because I have some questions. If you have a question, please go to the mic.
Hi, I have a question for the first speaker. I completely agree that physiotherapy studies are important and are needed. Inherently, physiotherapy studies are difficult, both because it's very difficult to do randomized controlled blinded trials with the physical therapy and because the choice of outcome measures are often difficult. What would you suggest as good outcome measures for these studies?
Well, that's a $64 million question. That's all my advisory board fears out the window. So I think the first point is I have a significant concern about sputum volume. So if you ever do 24-hour urine collections, everybody's in renal failure because they forget to pee in the bucket. So if you can't pee in a bucket, they'll not spit into a pot. And I also have concerns about if you've got somebody who's got really sticky mucus and they're coughing up nothing, increasing it is a benefit to them. And if somebody's got really retained mucus and you clear them out, it drops. So the average will probably look the same. And you'll have two really happy patients for completely different reasons. So I think, certainly in the UK healthcare system, the big thing is, does it stop you having exacerbations? Because all the cost is related to primary care visits and really, really linked to coming to visit me in hospital. So I think exacerbations are really important for those. And of course, exacerbation events are 1 or 2 per year, so you need a bigger study. So I think we need to frame our physiotherapy trials as simple but high volume. And actually, recovery and all the COVID trials just threw drugs at people, didn't measure much and said, were you alive or dead? And I think that's what we need to do for physio studies. Sign them up, loads of them, very simple. At the end of the year, did you have a flare-up or not? How many did you have? How many days antibiotics? So really simple studies. They're not complicated. Arietta's paper's got some core outcome measures for it, so that's the recipe. I may or may have not submitted to some of these recipes to the Health Technology Assessment Panel in the UK, which I happen to be one of the chairs of the panel, so watch this space. But I do think you guys need to be putting them in, and if anybody is from a UK background, because unfortunately it's a UK limit, please contact me. I deem it post in about 6 months, so this is the time to contact me. Thank you.
Is there another question in the room? So I have one question for Dr. Mensch. If I understood well, in your patient there is an improvement of residual volume, but not in FEV1. It's right?
The patient the case I described, yeah, he didn't get better. I mean, this patient is really, really ill, and I mean, he is, I didn't expect him to improve in FEV1. I just wanted him to improve in quality of life.
But how do you explain the improvement in residual volume without improvement in FEV1?
Actually, I didn't put this on the slide. The patient was really at the end of his life, so he finally deceased a few weeks ago, and I just think that he got less and less weak, and so the whole system was like collapsing. But still, I think this is a case where it shows that even in this phase of what other options would I have? He didn't want to have anything for the dyspnea. And this obviously helped him. So he was quite happy with it. And this is something, after this patient, I thought, okay, maybe I should do this treatment more regularly in all my patients which have problems there, because it seems to work even in this really difficult condition. Because sometimes in our, I don't know in your case, but in the COPD outpatient clinic, we often, I give them inhaled therapies, they get chest physiotherapy, they have inhalation. What else can I do if they don't want to have opiates? So I just have to do a symptomatic treatment. And for me, I think I'm also with you. So we need to reduce exacerbations. This is a really nice outcome if we have it. But on the other end, we also need to improve quality of life. And this, if you don't expectorate all the time, this is something that's really, really important for patients in their everyday life. We know it from cystic fibrosis. Since they don't cough up all the time, say, this is the best thing, I don't have to cough and don't expectorate sputum all the time. So this is the goal.
I ask this question because there are some recent papers with the possibility to have high resolution CT scan. There is some papers in COPD that emphasize the interest to remove mucus plugging with a significant increase in FEV1. This is a paper for Claudio that shows that an impressive improvement in FEV1 while we improve the mucus, they reduce the mucus plugging. So we can expect for this technique in COPD patients also to have the same effect. But maybe in your patient, it was very, very advanced.
I think he was just too ill to really improve. So I thought about this too, but some others did a little bit, but I think I can't do statistics and I don't want to do statistics. It was more about proving or showing, did it work for the patient? Did they improve in their quality of life? So this is a more important, but I think the randomized trials or bigger trials are important to just find out, can we improve FEV1? Can we improve exacerbations and quality of life?
This is a very important thing because until now, treatment for COPD are not able to improve pulmonary function tests. If it is true that this clearance technique are able to improve those patients in terms of FEV1, quality of life, and exacerbation, because this improvement is related to a reduction of exacerbation, is a big advance in terms of treatment of those patients. I have a last question for three, and this we are in front of a new technique, innovative one, and physiologically based technique. What is the place of this technique in your clinical practice? That is a first-line therapy? Is to addition to other instrumental therapies? That is physiotherapy, other devices, for example, a nebulization of a hypertonic solution. What is the place that you give that you envisage to give in the future to this technique?
Yes, because for the moment, as for each innovative treatment, you reserve this treatment to very severe patients like your patient. But perhaps in the future, we could imagine that to try in the treatment process of exacerbation, in the treatment process of sputum, of bronchial drainage, we could imagine to insert this technique earlier, perhaps, and the moment is to be determined.
Yeah.
I mean, and you asked just previously, you said that we had to do large clinical trials, but the fact is, what do we compare? because these COPD patients with a lot of secretions, they have to exercise, they have to stop smoking, they have to do bronchial drainage, etc. So this device added to good quality of life with no smoking and with exercise could be added very, very much earlier in the treatment, in my opinion. This is my objective in the future.
Of course. So of course you're asking the question I asked at the beginning, which is very clever, because where do all these things fit in? I think Pontus's case was beautiful that he'd already had an OPEP device, if I remember right, or some of the patients had had it. So I guess my analogy is you do simple things first and then you keep adding things on. So you do perhaps even active cycle or breathing technique in a bronchiectasis clinic, and if they're not doing well, then in our clinic we add a device in, and you keep pushing. I just wanted to highlight that maybe we've got things wrong. You add complicated things when you're struggling, and actually just remember you lose most lung function at the earlier stages of disease. So we're maybe being too accepting of things. And I think your point about mucus plugging was very good at the Fisher and Paykel thing earlier. That was really beautifully explained, as even patients with emphysema without much of a cough have mucus plugging and they do worse. So there's something happening in some of our patients' airways. So I think somebody with high sputum volume that's not responding to simple treatments, I think we need to be thinking about a different device. It might not be that device is actually what the patient really needs, but it's because they're not engaging with other treatment. We have to keep trying. If a blood pressure tablet doesn't work, we don't say it's a patient failure, we try another treatment. So you keep adding, but what I genuinely don't know, what you experts to tell me is, how long do you wait before something isn't working? How do you know? So you mentioned quality of life. Do these patients feel better at 2 weeks or 4 weeks? If you've got somebody in an OPEP device, do you wait 4 weeks to say, this is brilliant? Because they don't say that in my clinic of the simple OPEP. How long would we wait before in clinical practice do we change devices? I think a really key question. I don't know the answer.
And we always need to know, I mean, especially if we talk about devices and chest physiotherapy, my experience is that the first month after treating a newly diagnosed patient is not about like you have to do physiotherapy, inhalation, but it's he really needs to this really needs to be part of his life, and this takes not a few weeks. This takes months and months, sometimes more than half a year, until he say, okay, it really helps. My sputum is getting lighter. I have less sputum during the day, and if these concepts don't work, then for me the next step is more intensive treatment. Then it works with hypertonic saline and some training, that's fine, but there are some patients, and I don't have a big outpatient clinic, but it's 20 patients we tried it on.
So thank you very much for the speaker. If there is not more question, there is a hands-on practice on the device. You can approach to the table and you will have a demonstration. Thank you very much to the speakers and the audience for this session.